Okay, so the first test we're going to do is the Allen's test. We're testing for normal blood flow into the hand. What we're going to do is have our two thumbs over the medial and lateral side of the wrist and apply pressure. We're going to have the patient open and close their hand, and they're going to repeat this a few times. And stop. And then what we're going to do is let go one thumb out of a time, and what we're watching for is blood flow back into the hand. And a positive sign would be lack of color of return, meaning a lack of blood flow. The next test we're going to do is called the Bernal sign. We're testing for median nerve compression in the carpal tunnel. And what we're going to do is have the patient sitting with their arm resting on the table. What I'm going to do is just kind of tap along here against the flexor retinaculum. And a positive sign would be any tingling or neurological signs and symptoms in the median nerve distribution. The next test we're going to do is the Finkelstein test. We're testing for median nerve compression in carpal tunnel syndrome. What we're going to do is have the patient be sitting, and we're going to ask them to put the back of their hands together, just like that. So basically shoulders and elbows are going to be abducted to about 90 degrees. And their wrists or the back of their hands are going to be touching. They're going to hold that there for about a minute. And a positive test would be any tingling or neurological signs and symptoms in the median nerve distribution. Okay, the next test we're going to do is the Finkelstein test. We are testing for Dinker vein syndrome, which is a problem within the first compartment of the extensor pollicis brevis and the abductor pollicis longus. We're going to have the patient be sitting with their arm resting on the table. I'm going to passively move their thumb into their fist and move them into ulnar deviation, just like that. And a positive test would be a sharp shooting pain located over the first compartment, which is here. And that would be involving the extensor pollicis brevis and the abductor pollicis longus. Okay, the next test we're going to do is the Bernal test. What we're testing for is intrinsic, capsular, or extrinsic tightness. What we're going to do is start with the patient sitting here with their arm supported by the table. I'm going to passively extend the MCP joint and flex the PIP joint and take that measurement. And from there, I'm going to flex the MCP joint and flex the PIP joint and take that measurement there. And a positive test, so if there's an increase in PIP flexion from here to here, that would be a positive sign for extrinsic or intrinsic tightness. If there's a decrease in PIP flexion, that would be a positive sign for extrinsic tightness. And if there's no change in the PIP flexion, that would be a positive sign for capsular tightness. The next test we're going to do is the oblique retinacular ligament test. We're testing for oblique retinacular ligament tightness, capsular tightness, or extrinsic tightness. What we're going to do is have the patient sitting with their arm resting on a table. I'm going to passively extend the PIP joint and flex the DIP and take that measurement. And then I'm going to passively flex the PIP joint and passively flex the DIP joint and take that measurement. And then a positive test would be an increase in DIP flexion would equal a oblique retinacular ligament tightness. If there's a decrease in DIP flexion, that would be extrinsic tightness. And if there's no change, that would be a positive sign for capsular tightness. The next test we're going to do is the Finkelstein sign. We're testing for an ulnar nerve lesion. We're going to have the patient sitting, and they can have their arms supported by the table. I'm going to ask them to hold a piece of paper in between their thumb and index finger, and I'm going to try to steal the paper away from them. A positive test would be if while I'm pulling the paper away and their thumb flexes up just like that, or if I can steal the paper away from them. And that would be a positive test if the patient's thumb is flexed. that is caused by the flexor pollicis longus substituting for the abductor pollicis and the flexor pollicis brevis due to a ulnar nerve lesion. The next test we're going to do is the anterior interosseous test. We're testing for an anterior interosseous nerve, part of the median nerve lesion. We're going to have the patient sitting here, arm can be supported. We're going to ask the patient to make an OK sign with their tip, so of their thumb and their index finger. A positive test is if the patient's OK sign is pad to pad, and that indicates the flexor pollicis longus and the flexor digitorum profundus are paralyzed due to a lesion in the anterior interosseous branch of the median nerve. The next test we're doing is the Watson Scaphoid test. This test is used to assess scaphoid instability. We're going to have the patient sitting with their arms supported by the table in supination. I'm going to apply a ulnar force here at the scaphoid, and I am going to passively move the patient into ulnar deviation with slight wrist extension. While still applying the force on the scaphoid, I'm going to move the patient back into radial deviation with slight wrist flexion, and then release the force off the scaphoid. A positive test would be a thud or a click of the scaphoid, and that would be a positive test for subluxation of the scaphoid. The next test we're going to do is the Retinaculum stress test, and we're testing for carpal tunnel syndrome. What we're going to do is have the patient sitting with their arms supported by the table, their hands slightly off here. I'm going to passively move the index finger into DIP extension as far as I can go. And a positive test is numbness or tingling in the anterior forearm, and that would be a positive test for a median nerve entrapment in the carpal tunnel. Okay, the next test we're going to do is the first MCP stress test. We're testing for a ulnar collateral ligament tear, aka gamekeeper thumb. What we're going to do is have the patient sitting, their arm can be supported by the table. I'm going to passively move them into full thumb extension and apply a valgus force here at the MCP. A positive test would be pain in that region, meaning a tear in the UCL or accessory ligament. Then I can move them into flight flexion and apply a valgus force at the MCP as well. And a positive test would be any pain in that region, and that would be a positive sign for a tear in the UCL.